morning, everyone. Very happy to be here again, speaking on the same thing, but I promised I have added some more literature for you to review. So I'll be speaking about why stress CMR in 2023 is the best stress imaging modality. So my disclosures are that I am a multimodality imager, so I practice all the imaging modalities. But apart from that, what's close to my heart is, of course, cardiac MRI. And what I'll try to do during this debate is I'll try to give you the evidence that's out there for all the imaging modality and let the science speak. So the case that has been given to us is a 65-year-old female. She has hypertension, hyperlipidemia, unfortunately has a severe arthritis, probably is menopausal given her age, and she has atypical chest pain. Her EKG has non-specific STT changes, and the question that is posed in front of us is, what's the imaging modality? And also in the bracket is given rather than cardiac cath. And I have several problems with this. So of course, number one is there are no atypical symptoms. If the symptoms are present in a larger population, the symptoms are different than what we have known, but they are not atypical. Number two is I don't like the comparison with cardiac cath because gone are the days where anatomical testing used to be superior to any of the stress imaging. It is probably true for the macrovascular disease, but no more for combined ischemic cardiac disease. So the question that we are asking is, if this patient comes into my clinic, what my objectives in my mind are, I want to tell the patient what's the cause of chest pain. I want to figure out what's the cause of these non-specific STT changes. How do I get, this patient most information without doing many testing? So with one test, can I answer all these questions? What's the overall prognosis for this patient given these changes on the EKG? And what exactly does the patient need next? Whether it is anatomical testing or, before going there, probably a medical management. So when we look at the stress imaging modalities, I think what we need to look at, what is the accuracy of the test? What's the safety of the test? Whether that test is appropriate or not, given the patient's clinical context, what's the management and prognostic implications, and whether that test is cost effective or not, because we all will agree that across the world, whether it is United States or in India, cost has become a big issue for healthcare, and we want to help as many patients as possible at as minimum cost as we can. So I think what I'll try to take you through, we have been given 4 imaging modalities, cardiac CT, stress echoes, SPECT MPI, and stress CMR. And I will tell you what are the issues with others, hopefully make a case for myself by showing you the evidence. So let's look at the evidence, right? So if we look at the ESC guidelines for chronic coronary syndrome, meaningly angina, where does this patient fit? Unfortunately, we go back to the pretest probability data where this was defined by typical, atypical, or non-cardiac chest pain. And this patient is a 65-year-old lady, but we are told that she has atypical chest pain. So her risk is 11%. By definition, it falls into the low risk category. But if we take into consideration her postmenopausal status, probably I would put her at a higher risk, particularly for the overall ischemic heart syndrome, not for the macrovascular disease. The other thing is that this patient actually, in spite of whatever likelihood what we may say, she does have resting EKG changes. So that again, changes the overall pretest probability for the testing that you're going for, because you want to figure out why there are ST changes given on that EKG. Now, we are not being given the information on the EF, etc. So further looking at the guidelines say that the non-invasive testing, and this is both European as well as US guidelines, that you should consider non-invasive testing only if there is high pretest probability, if there is local expertise and availability, and if there is a viability assessment required. And I would say that given the amount of information that is given for our patient, I'm not sure if her EF is normal. I am not sure, what exactly this chest pain entails, and I would put her risk, higher, given that she's a postmenopausal woman. So if we look at overall sensitivity and specificity data for different imaging modalities, of course, here, there's a lot of variability. There are a lot of testing done since back in the day in 1990s, when many imaging modalities like cardiac MRI was still developing. So the numbers are all over the place. But I'd like to show you this paper in CERC, where they compared CMR and SPECT. And if you look at the sensitivity, right away, you can say that CMR has better sensitivity compared to SPECT. And when it comes to specificity, it's actually, they are both kind of the same. So there is higher negative predictive value with CMR, and that's probably because it's able to tell you about the vasculature, and it also does not have any phenomena like total ischemic dilatation or TID, as we know. So there is no balanced ischemia phenomena that we see with CMR, the way it works, and hence the sensitivity of CMR is much higher. Even with a negative CMR, you can tell 87% of the time, higher if you look at the recent studies, that a patient has, no evidence of ischemia at all. This is a paper, again, kind of on the same category, that this was published in Lancet. And if we look at macrovasculature, single vessel disease, triple vessel disease, left main disease, CMR was better than SPECT when it came to accuracy. Now, one of the things that accuracy, should take into consideration is less variability, because I think everyone here in this audience would agree that one of the main concerns with imaging testing, whether it is cardiac CT or its stress modality, is the variability between the readers, right? So whether it is the test is read in US versus in India, the test, the way it should look, whether the findings are subtle or very abnormal, it should be read consistently. And this is what was shown in this paper by Dr. Andrew Arai and Jack, where CMR really had excellent sensitivity, specificity, and excellent area under curve, showing that stress CMR actually is less variable compared to any other modality. And here I'm speaking to you, stress echo. So what about the safety? So of course, when I have looked up the nuclear stress testing in India, the predominant option yet given is stress thallium. And that makes me very worried, because the amount of radiation that is given with thallium testing is extremely high. And in my opinion, it should not be done. I think the nuclear testing probably, if you ask me, has a chance with stress PET, but otherwise, the amount of radiation with nuclear testing, both SPECT, whether it is thallium or any other tracer, nuclear tracer, it is so high that I don't think there are gone are the days when we do it. Particularly in United States, I can tell you it's being done because of the financial incentives provided by the government, by the Medicare insurance that is given to anyone above age 65. So now let's look at how does the CMR compared to cardiac cath. And if we look at the FFR group, not just with the solid macrovascular disease, but also with the intermediate disease, where FFR was positive, CMR in this NEJM paper did excellent and provided that information not only with the management, the referring provider was able to decide which are the patients to be taken for the stent stenting or for further intervention. Also, it gave excellent information about prognosis compared to FFR. So even when we look at the management and the prognosis, CMR is able to do really well. And because of this excellent prognostic value, the added advantage is that there is less downstream testing. If you are a referring provider, if I am a referring provider for a stress imaging modality, and when that stress imaging modality is negative, I should be able to sleep at night that my patient does not have any macrovascular disease that they are gonna drop dead in middle of night. And that's the advantage with stress CMR, the best prognostic data in comparison with any other stress modality. And then this is just yet another paper when we look at the prognostic value of stress CMR. And CMR is cost effective. So there has been multiple cost effective analysis that has been done. And of course, this data is for United States. I guess you may argue that in Indian scenario, it may not be, but I'm telling you, it's only next 20 to 30 years when this imaging modality will be prevalent in India. And that is because of the evidence that is backed up by it. It's a very contemporary imaging modality. It just, the first sequence, a proper CMR was done only in 1992. So it is actually younger than me, but I think that we will see a lot of stress CMR across the world soon. So again, one of the biggest advantage for the cost effectiveness is if a patient comes with low EF or ST depressions, and I want to see what exactly is the reason or etiology for that low EF, I'm able to give you all those answers. Function wise, if we look at the LVEF, CMR is the most accurate out of any imaging modality. It also can give you the initial valvular assessment. So with one testing, you not only get the accurate information about patient's ejection fraction, probably the reason for ST changes or cardiomyopathy. You can do the stress imaging modality and then figure out if there is any ischemia, and also look at the valves simultaneously and provide the prognostic information to the patient, to me, which is very important to inform to our patient what exactly all these changes mean. So I think I'm going to let this go. The most important thing that I want to reiterate from this is 30% of the women or 30% of the patients actually that present with chest pain have microvascular disease or INOCA. And CMR is a very effective tool along with stress PET, which can detect microvascular dysfunction. This is not done by echo and CTCA. And yes, stress PET has the upper hand because they have been validating this method for many years and it's used very commonly. However, I can tell you that the studies are done already to validate the stress CMR against stress PET in this scenario, where we can determine what is a patient's CFR in particular territory, before deciding that that patient is completely normal or not. I mean, completely, yes, if the patient has any ischemia or not. So just to give you an example, so this is probably a normal stress CMR. So you can see this is the perfusion. So by looking at the pixels that are there after the contrast is given, you can actually determine what is the blood flow that is at rest and at stress. So as we all know, in stress, the blood flow should actually double. And with this pixel wide analysis, you are able to tell if that blood flow is not doubled, and in that case it would look like this. And this color coding, it's red actually, which is abnormal and low. So you can see that these levels compared to the rest are low, and so this patient possibly has microvascular dysfunction. And this is just an example. The other way to figure it out is again by visually looking at the endocardium. So if we look at the microvascular disease, it will have this in spite of a normal EF, it can have this perfusion defect right in near the endocardium. So this is a case of patient with microvascular disease that was seen on stress CMR. So my point being is stress CMR can detect microvascular dysfunction, which cannot be done at this point by stress echo or dobutamine echo or CTCA. And if we look at, I'm going to skip this because Okay, so now let's come to.
We need to wind up. Yeah.
Okay, sounds good. So if we look at the CTCA, I think I order a lot of CTCA in my practice, depending on the patient I'm looking at. But my main problem with the CT is you have presented me a patient with chest pain. You haven't asked me to tell you if the patient had atherosclerosis or not. And now, after many randomized control trial, we know that ischemia and atherosclerosis are not the same. Anatomy and physiology is not the same. And the only testing that can tell you the answer with physiology is the stress testing. So the CTCA is very good with sensitivity, positive predictive value. I'm not sure, because not every athero means that the patient has ischemia. The whole left main argument that many interventional cardiologists or CT people will give you, that is flawed, because the left main incidence in this community is only, in worldwide community, is only 1 to 2%. So in general, we are not worried about left main, and left main can show up on any other stress testing as well. So in my opinion, with this and with ionizing radiation and stuff, CTCA is not the first good imaging modality. So what I've shown you is CMR is accurate, appropriate. It has, it's safe, it's cost effective, and it has excellent prognostic implication. I'm going to skip over this case that I wanted to show you. So what does this patient need? They don't need dobutamine stress echo, because dobutamine stress echo cannot detect microvascular disease. It has poor sensitivity, is variable from one person to other person. Stress MPI cannot be done. Too much radiation, it is not going to tell you EF or the cause of EF, and the accuracy is doubtable. And CTCA, I'm not here to tell you why the patient has atherosclerosis. My job is to tell you why the patient has chest pain. It won't tell you anything about microvascular disease. This patient, being a woman, has high risk of microvascular disease. It won't tell you EF if not done in a particular manner, and it leads to more downstream cath. Many studies have suggested that. So stress CMR will be able to tell you EF, will be able to tell you the cause of the symptoms. It has excellent accuracy, no radiation, cost effective, one test, less downstream testing, and hence it's safe, appropriate, cost effective, and evidence-based. And thank you so much.
So recently, the 2021 guidelines, that is American College of Cardiology, American Heart Association, and the Joint Committee on Clinical Practice Guidelines have come up with guidelines in entirety of how to approach a patient with chest pain. So first of all, initial assessment of chest pain is recommended to triage patients, okay? So instead of saying chest pain is typical or atypical, it would be more beneficial if we describe it as cardiac, possibly cardiac or non-cardiac, because typical and atypical words are out of context in this relativity. So this is how the chest pain is described, with red spectrum indicating high probability of ischemia, whereas green spectrum representing probability, low probability of ischemia. So what I would like to focus on is women present with chest pain. They have a risk of underdiagnosis, so potential causes should always be considered. And women are more likely to present with atypical symptoms. Now, this patient also has severe osteoarthritis. So, exercise ECG, TMT is out of context for this patient. Okay. So, over the past decade, the non-invasive testing has increased dramatically, and the scenario has changed a lot rather than invasive coronary angiography. So, again, any testing anywhere in the world is dependent to give more appropriate diagnosis, reduce layered testing, means one after another, or not doing the testing when the probability is low. So our patient here, 65-year-old female patient with severe osteoarthritis, with hypertension and dyslipidemia, with non-specific ST changes, according to me, falls in the list of intermediate risk. Okay, so she can either undergo anatomic testing, that is anatomic non-invasive testing, that is CT coronary angiography, or she can undergo functional testing, that could be any of these stress modality. Okay, so again, imaging will be testing choice will be influenced by site expertise and availability, which is a major factor considering our Indian population. Cost is also a consideration, and at present, CT coronary angiography cost is quite low, so it can be optimally utilized. So again, it is to ascertain the diagnosis of coronary artery disease and define coronary anatomy, or it could be to assess ischemia. For that, we need any stress modality. So now we come to CT coronary angiography. The CT coronary angiography will tell us about both non-obstructive as well as obstructive coronary artery disease. Not only that, in present day, it is the best modality to tell us what is happening in the wall of the coronary artery vessels. What is the plaque morphology? What are the characteristics of high risk or vulnerable plaque? Why is this important? Maybe this is not the cause of ischemia of the patient, but we can initiate preventive therapies, because everywhere in the world now the focus is shifting on preventive therapies, and that will have a long-term implication on patients' health also. What is new in CT coronary angiography? The addition of CT-FFR. Though it is a costly modality is at present, but what functional information CT coronary angiography was lacking earlier, now we can get with CT-FFR, and in future it will be widely available and widely used. So, as I said, CT can very nicely depict the compositional alterations within the plaque. I will show you few images also, and it can identify high risk or vulnerable plaque, which are independent predictors of major adverse coronary events. And recently, Williams et al. Reported that a low attenuation plaque is associated with a 6-fold increase in incident myocardial infarction for patients, even with though the patient has non-obstructive coronary artery disease. So it is very important to diagnose such patients also. So for high-risk features on CT coronary angiography include plaque morphology, which include low attenuation plaques that are less than 30 Hounsfield per units, positive remodeling, spotty calcifications, and napkin ring sign. And we can also do the evaluation of stenosis, where significant stenosis in left main is considered when there is luminal narrowing of greater than or equal to 50%. So this is an image of vulnerable plaque, where we can see this is the patent lumen. This entire one is the hypodense plaque with a atheromatous rim or hyper rim. That is why it is called the napkin ring sign, which can very nicely be seen on CT coronary angiography. This is just an image to show you how a maximum intensity projection can show a fibrofatty plaque with some amount of positive remodeling. Okay, with newer softwares, you can depict so nicely. See, these are the calcified plaques. We can see that calcium is orange color. Calcified plaques are stable plaques, how much luminal narrowing they are doing. So we can very nicely see all these things on CT coronary angiography. So now our patient falls in this category. Patient has stable chest pain and no known coronary artery disease. That is what we presume. So the patient comes in intermediate risk. So the patient can go either for anatomical testing, that is CT coronary angiography, or either of the stress testing modalities. If anything comes negative, we are okay. If something comes positive, we know how to progress with that pathway. But what happens when something falls in the intermediate category, where decision making hangs on how is the functional hemodynamic changes distal to the obstruction. So that is when CT-FFR comes into play, and especially for stenosis that is in between 40 to 90%, CT-FFR can very nicely tell us what are the hemodynamic implications. Again, see, the same thing, this is about CT-FFR that I said, but one another thing, if there is inconclusive prior stress test, then you should definitely go for CT coronary angiography, because then you can determine the presence of atherosclerotic plaque burden and obstructive coronary artery disease. The same applies vice versa. That is, if the CTCA is inconclusive, then you can obviously go for any stress study. But for intermediate high risk patients, this is very important, with stable chest pain but a negative stress test, and still you have high suspicion of coronary artery disease, then please go for CT coronary angiography as a non-invasive modality. It is a very reasonable approach. So again, if the low probability of ischemia, no testing is required, you can go for risk stratification. If there is intermediate risk, that is for a young, especially for a younger patient, less than 65 years of age or less obstructive coronary artery disease, then CTCA is still the preferred modality at present. If older patient and more obstructive coronary artery disease is suspected, then stress is the preferred modality of choice. He favors the factors that affect the use of CT coronary angiography is to detect obstructive as well as non-obstructive. This non-obstructive word is very important. Then high quality imaging and expert interpretation is routinely available. Age in younger patients, prior functional studies inconclusive. If there are anomalous coronary arteries or require evaluation of aorta or pulmonary arteries, the so-called triple rule out, where we can also evaluate pulmonary thromboembolism and diseases of aorta like aortic dissection. Moreover, we have seen female patients coming with moderate to large size hypertension also. For coronary evaluation, the gastric symptoms mimic as coronary symptoms. So this also has to be, this also can be seen on CT. So again, this is same thing, younger patient go for CT coronary angiography, otherwise go for stress. So what is the advantage of CT coronary angiography? That it is supported by a huge number of randomized control trials, as I will show you. And this also I mentioned that preventive intensification of preventive and anti-ischemic therapies is very important when we diagnose non-obstructive coronary artery disease on CT scan. Okay, and there is a high degree of concordance between CT and invasive coronary angiography obstructive coronary artery disease. So clinical trials have reported a higher diagnostic sensitivity of CT coronary angiography compared with stress testing for detective obstructive coronary artery disease. CTCA without stenosis or plaque has a low event rate of coronary adverse events. Okay, from PROMISE trial, 3-year coronary artery adverse event rate for negative CT coronary angiography was 0.9% for CT coronary angiography versus 2% for stress testing. Other randomized.
Apologies to interrupt. Could you please go to your wrap-up slides, please? We have 2 more speakers. Thank you.
Yeah. So other randomized trials include Scott Hart, then especially with patients for conserved trial. All these trials, since we are not able to go in detail, but all of them support and establish the superiority of CT coronary artery angiography in present study. And also they have in ED evaluation of patients with acute chest pain, CT coronary angiography leads to reduced time of diagnosis and prompt discharge. This is a very important factor that can be considered. Again, we have the CATCH trial which confirmed to these findings. Similar 40-month MACE rates were reported in PROSPECT trial also, while comparing CT coronary angiography with stress. So use of CT coronary angiography after stress testing also can diagnose or exclude obstructive coronary artery disease. ISCHEMIA trial, in ISCHEMIA trial, half of the screen failures were identified by CT coronary angiography, including those with non-obstructive or unprotected left main coronary artery disease. So that is also an important factor. Another thing is after a normal CT coronary angiography means no stenosis of plaque, the warranty period is approx 2 years compared to 1 year with stress testing. So observational registry data suggests that adding coronary artery calcium score in health checkup also can reduce diagnostic uncertainty and help detect atherosclerosis and guide preventive management. Again, CT-FFR is found to be highly coherent with invasive FFR, and its sensitivity and specificity are quite reproducible. So it has to be used when there is intermediate, that is 40 to 90% stenosis. When we are in doubt, there you can use the CT-FFR and a trial advanced registry has changed treatment after CT FFR in 2/3 of 5,000 patients. So that is a huge number. Okay, radiation consider. When we talk about CT coronary angiography, we cannot refrain from that. For prospective gating, newer softwares and newer machines, radiation can be brought down to 3 to 5 millisieverts. Triple rule out, I have already mentioned. What are the contraindications? Allergy, we know, inability to cooperate with no breath holding. Clinically unstable patients, you cannot go for CT coronary angiography. Renal impairment is defined by local protocols. If you are not able to beta block the patient, that is a contraindication. Arrhythmia, though with newer scanners, we don't have much issue with arrhythmia, and contraindication to nitroglycerin, if any. So for this patient, factors to consider when selecting optimal candidate for CT coronary angiography and why she is there. We presume she has no previous coronary artery disease. She is a case of intermediate probability. We presume she has regular heart rate, able to achieve a low heart rate. Her age is less than 70 years. If the BMI is also low, creatinine clearance is okay, no contrast allergy, then I would definitely go for CT coronary angiography in this patient. European Society current guidelines state that in patients, you should go, a stress test is recommended when there is significant ischemia. But multi-CT coronary angiography is highly sensitive, and even it is for rule out of coronary artery disease in troponin negative acute coronary artery syndrome. So that is a very important thing.
Yeah, so, you can wind up for the other speakers. Thank you.
Yes. So it can even independently predict the risk of myocardial infarction, cardiovascular death, urgent revascularization at a follow-up. So this is just a take-home message from this trial. So what I want to stress is women may be more likely to present with accompanying symptoms. Don't ignore that and share the decision making. That is what is important. Thank you.
Thank you, Dr. Kamal Sharma sir and the team for giving me this opportunity. And here, many of my friends are here, and 2 of my seniors from the same hostel and some juniors are also sharing the same platform now. So it's making me anxious as well as nervous. Let's see how it goes. I'll be talking on the approach to this patient, and I think everybody knows from the last session, last year also I was biased towards MR, but still I would try to make my point toward pharmacological stress echocardiography, especially in our Indian setting where we are facing cost constraints and availability issues. So history, we all know that our patient is 65-year-old, hypertensive and having dyslipidaemia. And as we now don't use the term atypical angina, we'll use to avoid ambiguity, we'll use possible cardiac chest pain. In this case, ECG is showing non-specific STT changes in inferior leads. Echo is normal without any RWMA, and as patient has bilateral osteoarthritis of the knee, so patient cannot exercise. Evaluation pathway in this patient will be estimation of the pretest probability, then using that pretest probability, then various stress tests available in this case, sensitivity, specificity, and accuracy of the test, and choosing an appropriate test out of them. So to calculate the pretest probabilities, I have taken this table from the recent 2021 SECHA guidelines. So our patient is 65 years old and is having chest pain. So she will fall in intermediate to high risk category. And the guideline also says that if we have availability of doing calcium scoring, coronary artery calcium score, we should do it to enhance the pretest probability. Now, coming to the clinical diagnostic pathway, as patient is falling in intermediate to high risk group, so we will have anatomical testing as an option and class 1 recommendation, which is preferred in less than 65 years of age, because in women with less than 65 years, they have
less chances of having obstructive coronary artery disease, and the CT coronary angiography is very good at ruling out the disease. And as our patient age is 65 years, so stress testing would be a good option, because definitely stress testing have very good ruling in power, and the stress testing which we can do in this case are stress echocardiography, stress cardiac MR, stress PET, and stress PET. Sensitivity and specificity of the various stress tests. Let us concentrate on pharmacological stress echocardiography. It has sensitivity of around 85 to 90% and specificity of around 75 to 90%. So it is almost comparable to cardiac MR, the sensitivity around 83 to 91 and specificity of about 86 to 81%. So various tests have range of clinical likelihood of coronary artery disease, where the usefulness of the application of the test is maximal. So here the ranges of the clinical likelihood of the coronary artery disease is demonstrated in the table, in which the test can either rule out or can rule in. The green line demonstrates the ruling out power of the test, while the red line demonstrates the ruling in power of the test. We can see from this table that CT coronary angiography has the best ruling out power, and if we concentrate on the stress echocardiography, it has comparable ruling in as well as ruling in power. When we select an appropriate test, we should also consider the likelihood ratio, which we calculate that by calculating it is the ratio of likelihood of having the test positive when the patient is having a disease to the likelihood of having the test positive when the patient doesn't have the disease. So it tells about the test ability to correctly classify the patients. So in stress echocardiography, the positive likelihood ratio of the test is 4.67, which is comparable to the stress cardiac MR, which is 4.54, and even the PET, that is 5.8. And the maximum negative likelihood ratio is with the CT coronary angiography. So definitely we know that it has the maximum ruling out power. Pharmacological stress echocardiography has the wide scope of applicability. It has many diagnostic and prognostic feature. This pharmacological stress echocardiography test can detect the abnormality at the most of the steps of the ischemic cascade. So the step 1 is the perfusion abnormality in the ischemic cascade. So it can be detected by using the real-time myocardial contrast echocardiography. Then would be the metabolic dysfunction. It will be detected by PET. The diastolic dysfunction can be detected by using tissue Doppler and the methods on stress echocardiography. We can even diagnose early systolic and early diastolic dysfunction using the tissue Doppler and strain imaging. And definitely we can visualize the regional wall motion abnormality on 2D echocardiography, and even the viability can be assessed by using stress echocardiography. Pharmacological stressors which we commonly used in the stress testing is dobutamine, which increases the myocardial oxygen demand, and another stressor which we use is the adenosine. It reduces the subendocardial supply, and it causes the coronary still in the subendocardium. The prime function of stress echocardiography is to detect the ischemia by various parameters, like we can detect ischemia by looking at the development of abnormality in systolic endocardial excursion, can detect by seeing the reduction in the overall ejection fraction after stress, by looking at the stress-induced ischemic dilatation in the LV cavity, and even the RV assessment gives us information regarding the ischemia. In this image, we can see that in the rest image, the LV looks normal, and in the post-stress, we can see the dilatation of the LV and also the decreased endocardial excursion in the apical septum and anterior valve. 10% of these patients have poor acoustic window, where comes the role of IV contrast agent, which will help in improving the visualization of the endocardial borders. Even perfusion imaging can be done using stress echocardiography. We can use the ultrasound enhancing agent. What we see in this perfusion imaging assessment is the replenishment of the contrast agent. Normally, at rest, the replenishment happens within 4 seconds after giving flash, and at stress, it happens earlier within the 2 seconds. In this image, we can say that replenishment didn't happen even at 4 seconds post-flash, and we can see perfusion abnormalities in the apical septum and apex. Even quantitative analysis methods like tissue Doppler imaging, color kinesis method, acoustic quantification, then strain and strain rate imaging, speckle tracking, echocardiography, this all quantitative methods can be used to detect early systolic and diastolic dysfunction in stress echocardiography. Even we can calculate coronary flow reserve by putting a pulse wave Doppler in mid to distal left anterior descending artery, and we can calculate coronary flow reserve. It is the ratio of the maximum diastolic flow velocity during the hyperemia to the maximum diastolic velocity at the rest. If the ratio is coming less than 2, it surely indicates the significant coronary artery stenosis. Even 3D echocardiography, 3D stress echocardiography has a role in ischemia evaluation with its advantages, like it can visualize all the segments in a single view, it will reduce the procedure duration, and it will avoid the apical foreshortening. Definitely, we can do viability assessment using a stress echocardiography. The typical response for viability are biphasic response, maintained improved response, and scarred myocardium will not move at all during the stress echocardiography. Simultaneously, we can do hemodynamic assessment, and we can even do assessment of valvular functions and structural abnormality when we use stress echocardiography. It has a good prognostic value also. If the test is coming negative, then the clinical cardiac event rate is less than 1% per year. And if the test is abnormal, according to the various parameters like transient ischemic dilatation, extent and severity of the wall motion abnormalities, coronary territories involved, presence and absence of RV ischemia, and time to develop RWMA, and the time to recovery, we can prognosticate the patients. So I would say that the pharmacological stress echocardiography has very good accuracy and efficiency with minimal cost involvement, and it will need minimal time also with no radiation at all, and it is environment friendly also. I can share one funny and relevant incidents also here that happened to me 7 years back. My uncle got a stress thallium done 7 years back, and he just came to our home, and I was pregnant at that time. And whenever he was about to come near to me, I would just run away from him. So I was just fearing the effect of radiation on the baby. So I would not recommend the test which has radiation involved, while we have available test which doesn't have any radiation involved and which can give the same desired information with the comparable accuracy. Then I would definitely go for non-radiation test. And on a lighter note, if your patient is claustrophobic, this is the only non-invasive stress test where your doctor will accompany you during the whole test. And in the last, I'll say that even the guidelines say that we should we should choose the test, and the choice of the test should be guided by the local availability and also by the local expertise. Thank you.
First of all, I would like to thank Dr. Sharma for inviting me for the interesting subject. And actually, the old speakers have told that that is a radiation. Nuclear medicine is radiation, but in recent times, nuclear medicine is mandatory in almost all the fields like oncology and cardiology. So, I am nuclear medicine physician, and I will speak about the nuclear medicine aspect of imaging. So, as we all know that myocardial perfusion imaging is important and critical aspect of CAD management, and it is almost for the 20 years because it is accurate, it is reproducible, and it is a marker of clinical risk. It is the article that was published 20 years back have shown that it gives a risk stratification. It stratify the risk in patient, divides patient into low risk and high risk. So it will prognosticate the patient, and management depends on the MPR results. And there is incremental prognostic value of spexity by addition of clinical MPI and ST segment variables. And now there are recent article that you can add the calcium scoring with the SPECT MPI results to further increase the stratification if we add the CT part in spexity. And after the introduction of the spexity, it gives a comprehensive assessment of anatomical and functional burden of coronary artery disease. It identifies the focal disease. It identifies the left ventricle function and volumes. It gives atherosclerotic burden, that CT part of PET, and also that is the most is it gives a diffuse disease, is the microvascular disease by CFR measurement. So coronary flow result, that is CFR, is this ratio of myocardial blood flow at rest, peak hyperemia to rest, and CFR exactly gives the hemodynamic effects of epicardial CAD, diffuse atherosclerosis, and microvascular dysfunction on myocardial tissue perfusion. So if we see the ischemic cascade, PET CFR is the first to detect the disease when it is at the microvascular dysfunction level, and also when PET and SPECT identify the disease when there is a decrease in the perfusion. And PET nuclear testing is also useful when there is arrhythmias, rapid heart rates, and poor acoustic windows. And other modalities are contraindicated when CT and MRI are contraindicated because of the one of the reasons. So if we see the pathophysiology of women have more non-obstructive CAD. They have plaque erosion with subsequent thrombus, and there is a endothelial dysfunction is more prevalent in women, and also have a lower vasomotor tone of coronary arteries, smaller epicardial coronary arteries, and thinner myocardial walls. So they're more prone to CAD. And so we will discuss our case, that is a 65-year-old female with hypertension, dyslipidaemia, that is, and patient has a preserved LVEF and bilateral osteoarthritis. So we will do the pharmacological stress testing in this case. Possible etiologies for angina, epicardial microvascular disease or coronary microvascular dysfunction. The cause of epicardial disease are the plaque rupture, stable plaque or bridging, or microvascular disease is usually because of the endothelial dysfunction. So CFD is more prevalent in women, hypertensive patients, and patients with the dyslipidemia. So in our case, this patient also have a chances of coronary microvascular dysfunction. Coronary microvascular dysfunction is not benign and has a greater implication for women with regards to adverse outcomes. So this chart is showing the distribution of cardiovascular risk by CFR. So if it is a CFR is normal, then there is a lower chance of cardiac related mortality. And if CFR is less, then there is a chance of higher chances of cardiac mortality. And if we see the CFR in the same CFR values for the female and male, then there is a female has a higher higher log adjusted hazard ratios. So now we can see what the guidelines say. So 2021 guidelines have shown that For the chest pain, this patient has a atypical angina and this falls into the maybe cardiac group. And according to the age, sex, and symptoms, this patient is falling into the intermediate risk category. For the intermediate category patients, guidelines say that either we go for anatomical or function testing, but we should know the patients has unestablished or known CAD, pre-test probabilities, prior test results, prior revascularization, and expertise and local availability. So and also further guidelines say that patients with older patient that is 65 year of age and more obstructive CAD suspected, patient should go for the stress testing. And because the goal of management is ischemia guided management, so this patient can go for the stress testing. And guidelines have suggested in the stress testing, PET and SPECT MPI is a most indicated. It then says evidence 1, and also class 1 2A evidence say that PET is reasonable in preference to SPECT if it is available. So this patient will go for the PET and SPECT MPI, either SPECT or PET, and it depends on the availability. And we have now newer softwares available that by that we can achieve the less radiation. See the radiation dose to the patient. So now we will see the cause of microvascular dysfunction, and now the management by how the PET diagnose the coronary microvascular dysfunction. So this is a patient with having a coronary artery calcium score of 0 and myocardial perfusion PET is normal, but this patient has a value of this CFR values are less than 2. So this patient has a coronary microvascular dysfunction. So that and also guidelines have suggested the stress effect MPI with the CFR management is reasonable to diagnose a microvascular dysfunction. But in Indian scenario, PET's CFR is not available because PET MPI is machines are available, but because of the unavailability of the radiopharmaceuticals and because of the logistic issues, PET MPI radiopharmaceuticals are not available, and there are some emerging evidence that SPECT MFR can be used for the diagnosis of obstructive CAD. So the paper of EJNM, that is 2019, have shown that low dose SPECT CT for regional MFR and diagnosis of obstructive CAD can be useful and has a good sensitivity and specificity. This another paper have shown that SPECT MFR can detect the multi-vessel CAD. Also, in comparison with the SPECT and PET, the JNM 2017 articles have shown that there is a good correlation was found with the MFR values with the both PET and SPECT, and also with the CZ to SPECT. The newer gamma cameras with the thinner crystals have diagnostic accuracy higher, and they can be used full for inavailability of the PET, and it may improve the MPI specificity. And also, if we are using the SPECT, we have to use attenuation correction or prone imaging to reasonable to decrease the false positive rates, because females have sometimes anterior defect or introseptal defect. So we have to do the prone imaging, and that will increase the false positive rate, decrease the false positive rate. Also, the guidelines have 2A evidence of guidelines have suggested the addition of coronary artery calcium testing can be useful in intermediate and high risk patients with stable chest pain and no known CAD. So now I can argue that this patient can go for the SPECT MPI in our Indian scenario, where with the new gamma cameras, with the new hardware and new software, we can use the stress first protocols to decrease the radiation burden to the patient. We can add coronary artery calcium score with SPECT CT or myocardial blood flow with the CZT SPECT. So we have to drive the patients according to the risk. So now I can conclude that nuclear medicine is best for this patient because it is a powerful test across the spectrum of CAD risk. Guidelines suggest the ischemia guided management in stable chest pain and intermediate risk group, supported by the evidence-based data. And pathophysiology of women is different. So women have more plaque erosion and microvascular disease that can be detected with PET. But PET is most accurate, but due to some limitations, we are not able to do PET MPI in recent times. So we can alternately we can use a SPECT-CT with the new gamma cameras, and these are the best alternatives after considering the old pretest probabilities and the history of CAD. And with the newer hardware and software, we can achieve the lower radiation dose for cardiac PET-CT and SPECT-CT. Thank you.